Hello everyone, and welcome to the National Headache Foundation's presentation on cluster headache. Today's speaker is Dr. Mark W. Green, who is the Director of Headache and Pain Medicine and Professor of Neurology, Anesthesiology and Rehabilitation Medicine at the Icahn School of Medicine at Mount Sinai, New York. He is certified in neurology by the American Board of Psychiatry and Neurology, where he is a fellow, and in headache medicine through the United Council for Neurologic Subspecialties. Dr. Green, would you like to begin?
Okay, thank you very much. I don't have a very formal presentation for you. I'd like to make this pretty informal, but let me begin with some kind of an off-the-cuff talk on cluster headaches so we kind of all understand where we're going with that. Cluster headaches are probably the most severe cause of periodic recurring headaches that we see. And I've had women who had cluster headaches who told me that it was worse than childbirth. One thing that comes up a lot is people get the sense that it's some kind of variant of migraine, and that's absolutely not true. Cluster headache is an entity unto itself and frankly unrelated to migraine. So I don't want to confuse it in terms of what migraine's about and migraine therapies, because we're talking about an entirely different condition. Also, cluster headache is quite rare compared to migraine, maybe 100 to 1. Interestingly, as a headache doctor, I see a lot of people with cluster headache, and I think part of the reason is that some with migraine may be doing okay on their own, or their other doctors may be comfortable managing them. But people with cluster come to medical care. They virtually always do, because these are so frightening, so serious, and at the time they're in a cluster so frequent that they're totally disabled. But interesting as we sort of talk about what goes on in cluster headache, an entirely different part of the brain is involved in cluster headache compared to migraine as well. So it's really a different syndrome. Kind of an overview of what they are. Cluster headaches are virtually always one-sided. The cases of two-sided clusters are incredibly rare, and they typically involve the same side, but not always. And some people will say to me, occasionally they shift in the middle of a cluster, and they'll say, well, the right-sided ones are worse than the left-sided ones, but they're much less likely to bounce back and forth compared to migraine, for example. Other difference, big difference in migraine, is that the pain comes on much more quickly. It doesn't come on like an explosion, like a hemorrhage in the brain, but they come on over minutes. Someone will feel often a feeling of pressure behind the eye, and within 4 or 5 minutes they're in agony. And migraines typically evolve over several hours. But the only good news, and it's just about the only good news I can give you, is that cluster headaches are shorter, typically lasting, let's say, 45 minutes to 2 hours. And I also should mention as we go forward that everything I've told you, there are tons of exceptions, and these are even true within an individual, so that people may have shorter clusters and longer clusters, etc. And during the time they're in a cluster period, which may last on average, let's say, 4 to 6 weeks, during that time they're vulnerable to attacks, and they may experience 1, 2, 3, 4 a day, again lasting perhaps 45 minutes to 2 hours. And unfortunately, these headaches have a predilection for occurring in the middle of the night. In fact, there was an old literature called alarm clock headaches, because people knew a long time ago that not only did they occur at night, but they often occurred at the same time. So someone would say, at 2:45 a.m. every single night, I'm awakened by this terrible headache. Also, I think the behavior of someone with cluster is entirely different from the behavior of someone with migraine. For example, someone with migraine wants to be left alone. They may scrunch their head in a pillow. They say, go away, turn the lights off, and hold still. Someone with cluster commonly just can't hold still. They pace. They do crazy things, sticking their heads out of the window in the middle of the winter, sticking their head in the freezer, all sorts of odd behaviors, but they're relentless. They pace, they can't hold still, and they rock. And they're not going to be the ones just lying in bed, typically. Light and sound sensitivity can occur in cluster, although it's more prominent in migraine. And nausea can occur in cluster, but typically is more prominent in migraine as well. Now, the period between clusters varies widely. Someone could have an attack and then 5 years later have another attack. In fact, a colleague of mine who had a couple of cluster periods a year then had no clusters for 20 years, only to recur. And I can't think of many conditions that would disappear for that long, only to recur again, and that's really odd. Migraine is typically genetic, and most everyone has family histories of it if they know it or not. Clusters are rarely genetic, although there are occasionally some family groups where everyone had cluster. But more often than not, people with cluster don't even know anyone who had cluster, unfortunately, and that's just a cross they have to bear. And I probably get rather aggravated when all their friends and neighbors say, "Oh, I had those as well," and they probably never had those as well. We don't know the cause. Again, it is generally not genetic. Occasionally, they've been reported after a serious head injury. One of the big correlations, which is interesting, is cigarette smoking. And there's some evidence that smoking cigarettes, that the smoke may activate a ganglion deep in the nose and may activate and bring these on. And I've had some people who found that when they stopped smoking, should they stop smoking, that it did give them some relief, although admittedly this is not invariable. But there is a relationship of cigarette smoking to cluster, and that's a problem in a lot of ways, many of them being very obvious, but one having to do with treatment. It may not be obvious, and I'll mention that in a few minutes. Diagnosis is made virtually by the history. There's really nothing quite like that. Typically, the pain's behind the eye. Occasionally, the upper teeth and the cheek. We call that lower half syndrome. And my experience says that people who have it in the cheek and upper teeth commonly get their teeth pulled out and sinuses operated on and all sorts of things done, which never gives them relief until it dawns on someone that this is, in fact, a cluster headache. But usually behind the eye and the temple is common. The pain is very deep. People say to me, I have a hot poker in my eye. But even superimposed on that deep, awful pain, one could get sharp jabs, which make it even worse instantly. And many of those jabs can occur within the headache. Another very prominent feature of cluster, which we can see in other headaches, but very prominent in cluster, are what we call autonomic symptoms: eye tearing and nasal congestion. So the eye may tear like crazy. The nose may get stuffy, but what comes out is a clear liquid. This is not a sinus problem and shouldn't be confused with a sinus problem, but it is often confused with as a sinus problem. And they may blow their nose as well. And that's actually interesting. It has to do with a reflex called the trigeminal autonomic reflex. And I suspect there are other people besides me out there who like vindaloo and maybe hot Szechuan cooking. And when you have that stuff, it's very hot, your eye will tear and your nose will run, and that's because we've activated these particular pathways. Or if you don't like those foods and you have no experience, go outside in a very cold day in the winter, and your nose will get stuffy and your eye will tear. And that's simply activation of that particular reflex. So that the diagnosis is made by history, and that's adequate. I've been doing headaches now for almost 34 years, and it is incredibly rare, perhaps almost never, when what sounds like cluster isn't cluster. And although the literature talks about cluster lookalikes, when you actually look at those cases, and I have over the years, they generally really weren't good stories for cluster headaches. I'm not sure there's really anything quite like a cluster headache. Treatment. Well, we use, when someone has a cluster headache and they present to the office, we're extremely aggressive in the treatment. We're certainly interested in what they used before, had they received this diagnosis and treatment in the past. And if they had a regimen that was very successful, and there's no reason not to, we'll certainly try and replicate that. But many people we see, in fact probably most, don't have a clue what's wrong with them, have never been treated, and often come in absolutely just, they've had it. They haven't slept because it wakes you up in the middle of the night, the alarm clock headache. They're afraid to go to sleep often, and they're sleep deprived, they're angry, and they just had it. And we always worry about suicides. The fact is, there's a substantial suicide rate in the cluster population, so we treat them very seriously. And what we do, typically, if it's very, very severe and they're in the middle of a cluster period, we'll give them high doses of steroids, corticosteroids if we can, and they're very effective if the dose is high enough. The problem is you can't give people high doses of steroids forever, and clusters can go on for months. Let's call them regular preventive agents. They may be helpful, less helpful than steroids, but even when they work, they take weeks to work. So the bridge is steroids. And the other medications include verapamil, and the verapamil is often used at a very high dose, often surprising the internists how high a dose we use, with something else. that something else is often topiramate or divalproax, marketed as Depakote, or lithium carbonate, all of which can be effective. But we usually use two drugs together for prevention, plus often the steroid is a bridge. For acute treatment, because these drugs are helpful but they're sure not perfect, what do you do when you get a headache? Well, there are two things that tend to work. One is oxygen, and we can talk about that later. Oxygen inhalation has a fairly decent success rate, and it's very safe. That's what we like about it. And the other are triptans. And triptans, as you may know from the world of migraine, and I strongly suspect that everyone listening is very educated in the world of headache, the only triptan that's approved for cluster, and frankly, the only one that's really appropriate, is injectable sumatriptan. The nasal sprays, occasionally people will say they're helpful, but the FDA has not approved them. You know, in a migraine study, you have to show that something will work in 15 minutes. I'm sorry, 2 hours. In a cluster headache study, you have to show it will work in 15 minutes. So the only one that made the cut was injectable sumatriptan, and we can talk about that as well. There is no evidence that after your cluster period is over that you need treatment, and people often get superstitious. These were so terrible, they don't want to stop the preventive drugs because they're worried that if they stop them, they'll come back. Well, guess what? They'll come back anyway, so there's no purpose in being on a drug for 6 months or a year or 2 years waiting for it to recur. So as soon as the coast looks clear, we taper people off slowly, make sure the coast is clear, and then they're drug-free. Another striking thing is effective alcohol. I've never seen a headache so responsive to alcohol. People with migraine often will tell me, you know, red wine and those things will trigger it, but people with cluster may have a sip of wine or a sip of champagne. I mean, minor amounts, and within a very short period of time, be very, very ill. And although that's not diagnostic of cluster, it's very, very suspicious of cluster. So I don't want to take up the whole night just lecturing to you. That's not fair. I'm kind of interested in what you have to say and any questions you may have about this terrible condition. Zach, can you help?
Yes. So our first question is from James, and he's actually asking about, in regards to Medicare, a 2011 decision memorandum for home use of oxygen to treat cluster headaches. In that Medicare decision, it refuses to approve oxygen for home use for cluster headaches unless patients are participate in an approved study. Do you have any comment on that?
Yeah, I know about it. I'm appalled by it personally. I think it's terrible, it's mean-spirited, and it's a law that was clearly made by people who don't know anything about the subject. You know, cluster headaches. One thing about oxygen, I think injectable sumatriptan is probably more effective and more effective more quickly, but oxygen is safer. There's unlimited use fundamentally, so you can use as much as you need. Frankly, in the long run, it's a lot cheaper, and it should be approved. If you benefit from oxygen, that's the one good bit of news these people have, that there's a very safe drug that they can use to abort attacks. And so I think it's just awful. You know, one of the problems you see with cluster, and I suspect we'll come back to this tonight, is has to do with marketplace. You know, the FDA is not going to approve a drug very often, or I shouldn't say this, a company won't bring a drug to the FDA for approval where there are not a lot of people who would need it. It's very expensive to do a trial to get FDA approval, you know, and who's going to spend $500 million to sell, you know, 1,000 prescriptions. So it is unfortunate and unfair that we have so little data support by industry from about the treatment of a drug, of a condition that's relatively rare, yet very, very disabling and very painful.
Along the lines of the sumatriptan injection comment you just had, Rob is wondering if taking sumatriptan injection and verapamil as a preventative is the best suggestion for him. He's found that that works more effectively than oxygen as well as the sumatriptan inhaler.
No, yeah, no. Well, firstly, I don't want to confuse the two things. The verapamil and anything we might add to it are preventives. The sumatriptan injection is an acute therapy meant to stop an individual attack. We don't use that preventively. And in fact, preventive triptan studies have failed, which is interesting and unfortunate. So taking a triptan like twice a day or even preemptively for an attack generally doesn't work, although I don't know why it doesn't, but it generally doesn't. Injectable sumatriptan is very, very effective. And the problem is that a lot of these shots are $100 a shot. It's possible to need 3 or 4 a day, although we have a few tricks up our sleeve. A lot of insurance companies will say, I'll give you 2 a month, and that doesn't make it through an afternoon. And again, makes it even worse how the government's taken this position on oxygen, which, again, no one's saying it's better than sumatriptan. What I'm saying is it's easier, it's cheaper, and it's another tool. And people with cluster need all the tools that they can get.
Along the lines of the verapamil, James is asking about the way the verapamil works. He says that it's a vasodilator and was used during a couple of cauterizations of his coronary arteries instead of the normal nitrotriglycerins because of concern about provoking a cluster headache. How can it not provoke a cluster headache along the lines of a nitroglycerin?
Well, firstly, the theory that all this has to do with blood vessels constricting and dilating is really outdated, unfortunately, and it's a kind of stuff we talked about years ago, but we're not concentrating on that. So I don't think you should think of verapamil as a vasodilator and think of cluster as a vasodilator type of headache. Probably involved to some degree, but it's not the center of the universe. So don't think you should even think in that way. But having what you said about nitroglycerin is true. There was some really interesting, this is kind of cruel, if you read about cluster headache in the 1940s, I think it was 40s, the very famous doctor at the Mayo Clinic, Dr. Horton, firstly decided to call them Horton's headaches, which I guess was a good try on his side. But what he described was he would give people who he thought had cluster headaches a little bit of beer, and then he'd come back in an hour, and if they were kind of writhing around in pain in the waiting room, he said, aha, I've made the diagnosis. Well, I don't think we need to do that to people to make the diagnosis, but it's been known for a long time how striking that alcohol effect is.
James is also wondering if you've had any success with treating chronic cluster headaches with a 10-liter concentrator at 96.4% oxygen purity.
Well, I think there have been a few safety issues about high flow forever. I don't have a lot of concern about high flow to abort an attack, which may be an hour or 45 minutes. But I'm not sure we've established the safety of very high flow vent continuously. We have done some work, and this is not something we do too often, but sometimes it's helpful in terms of an awakening, is to use oxygen through nasal prongs, which generally does not deliver enough oxygen that people sleep with. And it kind of raises the level while they're sleeping at night to try and reduce some of the awakenings. What he does bring up is a really important point, however, that I should mention, particularly since the government is not helping us in the world of oxygen. Oxygen was traditionally used in a very large cylinder, really ugly thing that needs delivery and very heavy and could fall, and kind of a big deal. And the oxygen concentrators delivered 4 liters a minute, which was really not enough for cluster headaches. A few years ago, several companies have put out oxygen concentrators, meaning you don't have anything delivered. You have this device that kind of looks like a dehumidifier on wheels, and you pull it out when you need it, and it delivers 10 liters a minute, which is usually fine, with a particular mask, which you can buy, called the non-rebreathing mask, which has a bag. And you breathe it in until you're comfortable, and then 5 more minutes. What I found is that people treat it until the headache goes away, and they immediately take it off. The headache tends to come back. So I say use it until it goes away, plus 5 minutes. And, it's not perfect. Injectable sumatriptan's better, but it's pretty good, and I think very safe for this episodic use. Oh, I should also mention, if you have coronary artery disease, like was described here, heart disease, you can't use a triptan. It's not an option.
Walt actually has a question about the injectable sumatriptan. Is this a regular injection in the hip, or is it an infusion via an IV?
No, it's subcutaneous underneath the skin. There's several ways of doing it. There is a needleless injection that's marketed under Sumavel. It's really easy to use. There are needled injections that were the original Glaxo one, and now some generic companies. There's one called Alzuma that Pfizer makes, and these are all kind of auto-injectors like pen injectors. But an interesting thing about sumatriptan is they usually come as 6 milligrams. I mean, some companies make a 4, but generally it's 6 milligrams. And many people find that they can use 2 milligrams per cluster. They don't need 6. And what they do with our prompting is to buy the vial, which is cheaper, and draw it up in a little syringe and a small needle, and learn to inject themselves, which isn't really hard. These are tiny little needles. And then they can often get 2 and occasionally 3 treatments out of 1 vial, which takes this incredibly expensive treatment and at least makes it, you know, maybe a third to the half of the price, which is still very expensive, but better than nothing. So it's something to consider. And also, 6 milligrams is often more than people need anyway. You can get flushed. Sometimes it makes the pain worse early on. And 2 may be more pleasant.
Well, was also wondering if you've heard of a drug called ketamine being used in trigger points to end a cluster headache.
No, trigger point ketamine I'm honestly not familiar with. Ketamine by nasal spray has been used. We have some experience using it intravenously. This is an anesthesia project. This is not something you do at home. Unless you happen to live in Beverly Hills, we don't like to deliver anesthesia at home. Unfortunately, and it's a very extremely tightly controlled drug. So I hope in the future, because it's been abused a great deal, that maybe we'll get some, it'll be easier to get this and have some more delivery systems. But unfortunately, there's not, you know, there's not a lot of practicality for home use at this point.
All right. Ashley says, I have headaches often, and I'm certain that 2 different types of headaches are occurring. Is this normal? For instance, I have a cluster headache symptoms regularly, but last night I had a headache that came on quickly and had me sick on my stomach, as well as had a sensitivity to light. Could I be experiencing both migraines and cluster headaches?
You can, but and you know, obviously I don't want to give you a diagnosis on the telephone, but it would be pretty unusual if you have cluster headaches. They're really quite distinctive, and cluster headaches have this pattern. It's not just that kind of headache. It's you're getting multiple ones per day, often for weeks and months, in a very specific, repetitive pattern. You don't get them here and there. Much more likely migraines, because migraines occur in lots of different flavors, and many people with migraine experience what they interpret as 5 or 6 or 7 or 8 different types of headaches.
Jean asks, or says that the use of oxygen to limit cluster headaches, but awakens the question her if any research has linked these nighttime awakenings of headaches to sleep apnea. Are you aware of any links between sleep apnea and cluster headaches?
Yeah, there are, and sometimes we will do a study called the polysomnogram to see if there is sleep apnea, and sometimes that's helpful, so that the desaturation that you can get in the middle of the night with sleep apnea, in other words, you don't get enough oxygen in your blood, can become a trigger. Also, a lot of people with cluster tend to be obese. Again, they're cigarette smokers, and they're often way overweight. Those things tend to come together, and overweight people have a high incidence of sleep apnea. An old study that's much less depressing than what I'm talking about that I found interesting, and I see a lot of it in my practice. Dr. Graham, John Graham at Harvard, who passed away about 15 years ago, showed that I think it was Dr. Kudrow, Lee Kudrow, that most people with cluster headaches had hazel eyes, or not most, a very high percentage had hazel eyes, which are otherwise rather uncommon in the general population. So if you know anyone with cluster, see if they have hazel eyes. It's kind of interesting.
All right. Susan is actually wondering what is considered a high dose of Vermin.
Sometimes 720 milligrams, occasionally even higher. And there are problems with that. You don't just do that at home. We do EKGs to make sure they're not developing heart issues, make sure the blood pressure isn't falling, and it's not, no one starts with that. But sometimes 720 or more is needed to control the cluster headache. And those are not, you know, the common doses. I think most people out there are used to 80 or 120 or 240, but not used to those doses. So they're high.
Linda is wondering what symptoms she should be looking for in terms of having cluster headaches. She says that she has severe headaches behind her right eye, and she thought they were migraines because she had watery eyes as well, but she also has nasal congestion, light sensitivity, and paces instead of laying down. Is there a likelihood that that could be along the lines of cluster headache?
It's possible. Again, you need to know more. Single attacks here or there are very unlikely to be cluster again. And migraine can do a lot of these things too. A migraine can cause eye tearing and nasal congestion. Anything that hurts a lot, like I said, like Szechuan cooking in burning your nose can cause eye tearing and nasal congestion. So again, I can't make a diagnosis. We would spend an hour with someone like this in the office, but it's less likely to be cluster than migraine or something else. Many kinds of headaches occur behind the eye, many, many kinds. And the reason for that is that most of the structures in the brain that are sensitive to pain receive a nerve supply from the same nerve that supplies the area around the eye and the temple. So these are common referral areas. You can be fooled. So again, let's keep it pure. Cluster headache are recurring attacks, usually one or more a day, lasting several weeks, and then with periods of remission. Although admittedly, there are lots of exceptions. I guess I didn't talk about chronic cluster, which is where they still occur the same way I told you, but people don't get remissions, which is even scarier, and that's even harder to treat. And usually we'll use verapamil and lithium carbonate to treat that. That's a very common regimen.
Rep says, I am in my late 40s and can remember this pain all the way back to my mid-20s. I've read plenty of studies that as you get into your 50s and 60s, cluster headaches can fade away. How is that true?
It's not. Anything can fade away. Unlike migraine, clusters are less likely to fade away. I don't want to bum you out. And one of my patients was 102 or something like that, still had clusters. So anything can go. As I said, they could go away tomorrow morning and never be seen again. But age is a predictor of them going away. This is not migraine. It may not be true.
Also, do you recommend burning or freezing of the nerve as a treatment, such as an infraorbital nerve block?
Well, those are done from time to time. The couple things you do. One is you want to make sure it really works. So no one should burn or freeze or anything in the nerve until you're absolutely certain on several occasions with local anesthetic that it really, in fact, blocked the pain, because there's no one nerve that conducts the pain of cluster headache. The other thing that you can see is you can do an infraorbital block and a cryoablation, and everything looks good, and then the next time the cluster switches to the other side. So you can chase around nerve blocks forever. So the temporary ones are very safe. It's always worth a try. But before one does a cryoablation or a radiofrequency ablation, a little bit of caution there.
And have you heard of any effect of a nerve stimulator surgically installed in order to ward off those types of cluster headaches?
Yeah, well, the one that we have most interest in, and I think that's true in general among headache doctors, is the one that implants a device in the hypothalamus of the brain. If I was saying earlier that migraines and cluster are different parts of the brain. In migraine, you hit an area called the periaqueductal gray that gets activated during that attack, and in cluster, there's an area in the hypothalamus which gets activated, the hypothalamic gray. And so there's different anatomy, but what's sort of interesting about that, and wasn't surprising, is that that's an area of the brain that conducts circadian rhythms, these regular biological rhythms. And if there's anything odd about cluster, it's how regular and rhythmic and recurring it is. So that sort of biological clock is driven by the hypothalamus. And there implants into the hypothalamic gray, very much like it's done for Parkinson's disease and sometimes for epilepsy, in some studies have been shown to be very effective. However, they're not FDA approved yet. This is still research in the United States. I think it's a group in Italy that's done more than anyone else, but one just doesn't go to their local neurosurgeon to get a hypothalamic stimulator these days. You have to be part of a trial, and there are very few trials in the country going on.
Jeff also asks, is there any understanding as to why cluster headaches may begin after months of remission?
No, that's such a key question, and if we knew the answer to that, we'd really be in great shape. And he and I always wonder about that. Why do they come on all of a sudden? And then once they've come on, what flicks the switch to turn them off? Because even if we could just flip the switch to turn them off, all these other things really wouldn't matter. And we don't know, and it's one of the great, whoever solves that problem has done an amazing thing for cluster. So we don't know. We just don't know.
Do you have any explanation as to why cluster headache episodes are getting progressively longer with each occurrence? Should someone be concerned if those episodes are getting longer and longer?
You know, that doesn't have to happen. In fact, they're all over the place. You could have a particularly terrible cluster, followed by a particularly mild one, followed by a terrible one. So there's not necessarily a statistical trend for them to worsen over time. So don't count on that. Hopefully it won't be the case over time.
Magnesium supplements have been used to help with migraineurs, but would magnesium supplements help at all with cluster headaches?
No, I've never found them to be effective. Even intravenous magnesium, which can help a little bit, helps in a small percentage of people with cluster. So it's not a major treatment for cluster, even intravenous magnesium. But again, this is not migraine, and magnesium can be of some value for migraine. It's probably not much value in cluster. I'm not sure any of these herbal therapies have been shown to be terribly effective in cluster either.
So do you know of any non-traditional methods of treating cluster headaches?
No. I mean, there are a lot of things that have been brought up and tried, and none of them really holding up. So we're not much in the way of herbalists in the world of cluster. Again, this is not migraine, and some of the herbal treatments in migraine can have some value, but it doesn't look like in this world it'll be of value.
Ashley's saying that during both of her pregnancies, she did not experience any type of headache, but after delivery, they started again. Do you have any advice as to why that might happen?
No, it's very unpredictable in cluster. It's pretty predictable in migraine. In other words, her story in migraine is generally going to be the case, where 2/3 of people will get better during pregnancy, particularly the second and third trimester, and then it may all fall apart after delivery or after breastfeeding commences. But in cluster, it's much less predictable and much less under that kind of hormonal control. Go to hormones, and I should have mentioned it. One test that we do in males is we check their testosterone level. It's often abnormal, and often if it's abnormal and you treat it, it can give people some relief. And that hypothalamus is a part of the brain that is involved in a lot of hormonal issues. And so even if someone's really struggling to, even an endocrinologist to kind of do a good screen for a variety of hormones may be of some value, although it's not something we usually do.
Have you seen any successful treatment with high doses of corticosteroids for the inflammation that occurs, or is use of corticosteroids not for inflammation at all?
No, corticosteroids are great. I mean, corticosteroids work like a charm. Very few people don't do beautifully when they're placed on 80 milligrams of prednisone, for example. The problem is, how long can you do it? 80 milligrams of prednisone, isn't safe to take for 3, 4, 5 months while you have a cluster. And so we do it, as I mentioned in the beginning, as a bridge, hoping we can at least keep you feeling human while we're waiting for the other drugs to kick in. And a lot of people are very grateful for that, because a lot of people come to see me, as I said, have just had it. They haven't slept in days and days. They're afraid to go to sleep. They just really had it. And if you can give them 80 milligrams of prednisone or something like that, and they get their first decent night's sleep, and at least they get a break for a few weeks. But you've got to eventually lower these steroids, and more often than not, when you get low enough, they return. But you're hoping that your preventive drugs, verapamil, whatever you use, start kicking in by that point. So steroids are great. If they were safe, we wouldn't need to talk about many other treatments.
We also have one more question from Ashley, who is wondering if she should see a neurologist prior to getting any kind of sinus surgery or procedure. She hasn't really been able to narrow down which type of headache she's been having, but she's thinking about the congestion that always occurs along with the pain behind her eyes.
It sounds like you should, honestly. I mean, I don't know the details of this, but there's such a bad history of people getting sinus surgery for what are really trigeminal, we call them trigeminal autonomic disorders, where it's really part of the headache syndrome, and the sinus surgery doesn't do anything. So again, I don't know the specific deal, but I would see a headache doctor, an expert, before I went running off for sinus surgery for headache. I don't know if the group is all aware of this, but at least chronic sinus disease by itself is really not accepted as a cause of headache. And acute sinus disease can cause it, but they're not periodic and recurring, and it doesn't go on forever, and you have pus from the nose, etc. So we're very suspicious of sinus-like stuff that's blamed as a sinus problem. Because there was a study by Kurt Schreiber who looked at people with so-called sinus headache, and something like 88% had migraine on further review.
Well, that's actually all the questions we have for today. So thank you very much for joining us, Dr. Green, and thanks for answering all these questions.
My pleasure. My pleasure. Thank you all for listening.
All right, that's the end of the webinar. We will be having webinars later in the month as well. You can check our website, and our webinars will be listed as soon as they are available.